Hi, dear students. A very warm welcome to all of you in this uh, live clinical case challenge. And today I have with me Dr. Bharat Kathi. He will be discussing a case of breathlessness, and we will look at questions in between and find out what you think, how you approach a case. This is an actual case that Dr. Bharat saw in his clinical practice, and we will be discussing about how he approached the entire case in his real life. And another thing that I want you to know is that Dr. Bharat is right now working as a COVID specialist in Tirupati, and today he had some time to do a clinical case discussion. So I asked him to spare this time, and he's been very kind to do this for us. His practice is right now going very busy because of the COVID pandemic. So without wasting any more time, I will get Dr. Bharat online so that we can have a quick discussion with him. So let me add Dr. Bharat here. So Bharat, how are you feeling today, and how are things back home?
Yes, sir. Things are not that satisfactory here because day by day cases are increasing. And being a frontline health worker, we should do our part in this pandemic as national duty. So hope all these things will settle down, and I'm actually waiting to meet our students live as soon as possible, sir.
And Bharat, now that you're working as a full-time COVID specialist in Tirupati, what
Yes,
I
sir.
wanted to know from you was that any particular precautions that our children should be taking who are going to give the AIMS exam in 2 days?
Yes, sir. Definitely, they should make sure they're frequently sanitizing their hands so they're not touching their nose and mouth and wearing a face mask. If at all they permit, you can also wear one face shield. So as of
Okay.
now, I think giving exam. So when you take the pros and cons, because still our government has given some advisories. So most probably AIMS will follow those advisories. Few people may miss out the exam, but if it is mandatory and if it is inevitable to give the exam, you should make sure that your hands are clean. Always sanitize them. So don't touch your nose and mouth with those hands. Wear a mask, and if they permit, also wear a face shield. So that will give you some amount of protection, definitely.
So your work that you're doing right now is very inspiring, and all of us in DAMS are very proud of what you're doing. And now let us start
Thank
off
you.
with the case discussion for today. And Bharat, you told me that this is one of the cases of your own practice,
Yes,
and I
sir. Yes.
think there's a lot to learn in this particular clinical case.
Yes.
So, are you all children who are listening to us right now? Are you all ready to play the game? Are you all excited? Yes. Are you all excited? So, whenever we ask you a question, I want you to type your answers, participate in the case discussion. More you participate, better you will learn. So, please keep your fingers on the keyboard. Okay. So, let's start with the first, slide of the day. Okay. So, this is the case that we are going to discuss with you today. This is a 62-year-old female who was referred to chest clinic to Dr. Bharat by her family doctor. She had a 6 weeks history of increasing shortness of breath, which is now problematic at rest. She had occasional dry cough, no fever, no orthopnea, no palpitations, no chest pain, no syncopal attack, no pedal edema. Her history otherwise is unremarkable. On journal examination, she is conscious, coherent, no pallor, no jaundice, no cyanosis, no clubbing, no lymphadenopathy, and vitals are stable. This is the clinical history that we have with us by Dr. Bharat. So the first question we want to ask you here is, what is breathlessness? Okay, and we will have Dr. Bharat to tell us here. But before he tells, can you start telling us that what do you think we mean by breathlessness? What is shortness of breath? What is dyspnea? What is your impression of it? Any answers?
Yes, all these terms mean the same. So breathlessness, shortness of breath, dyspnea, difficulty in breathing. So first we will see a simple definition. What is breathlessness? So if they ask you even in your final year exam, so they'll ask you what is meant by breathlessness. So tell me the simple definition and tell me the medical definition given by American Thoracic Society. Yes, what is
Well,
breathlessness? Yes, very good. Subjective perception of difficulty in breathing. Yeah. Yes. Unpleasantness, awareness of one's own breathing. Yeah, just 1 minute. Yes. Yes, difficulty in breathing. Yes, yes. So this is just a routine definition. So difficulty in breathing or subjective awareness of one's own breathing is undue awareness, difficulty in breathing. Yes. So this is a definition in simple language. Let us see the medical definition given by American Thoracic Society. So this is this definition that you should know. Subjective experience of breathing discomfort that consists of qualitatively distinct sensations that vary in intensity. So this is the actual definition given by American Thoracic Society. So they tell that breathlessness is not just a breathing discomfort; it is also having some psychological psychological symptoms such as some distinct sensation of unpleasantness. So that's the reason. So it is not just difficulty in breathing; it has some psychological impact. So that is called as distinct sensations that vary in intensity.
And I think, it has all become so important nowadays with COVID and hypoxia. It's very, very important, I think. So the next we have is, what is the neurophysiological mechanism of dyspnea? You can, type a little bit here and we'll build on and we'll tell you what exactly happens. But I want the students to start typing and say whatever they think. What is the mechanism behind dyspnea? You told us what is dyspnea, but what is the mechanism before Dr. Bharat tells us? And any answers you have.
So actually, dyspnea has the complex mechanism of all the symptoms. So that's why this is something not covered usually in your routine teaching. So here we are trying to incorporate the neurophysiological mechanism of dyspnea. So let it be any cause ultimately leading to dyspnea. What is the exact mechanism? Yes, air hunger, hypoxia, hypercapnia. So they can cause dyspnea. Anything else? Hypoxia, hypercapnia. So that is one of the reason, hypoxia, hypercapnia. So afferent, efferent mismatch. Okay, we'll see what is that afferent and efferent mismatch. So J receptors, yes, that is also one mechanism causing dyspnea. The decreased oxygen saturation, yes, that is also a cause of dyspnea. Okay, so medulla oblongata, yes, neuromuscular problems, very good. That is also one cause of dyspnea. Chest wall deformities, yes. Okay, let me try to put it in a simple manner. See, for any symptom to happen, there should be some stimulus. So this stimulus is picked up by body's receptors, and these receptors are called as afferent receptors. So there is some input to your body. So this stimulus is carried and integrated in the higher center. So once it is integrated in the higher center, so that higher center will give you a response. So that response will come out as the manifestation. So very simple. Afferent input is with the help of chemoreceptors. So chemoreceptors, they will be in the carotid body, aortic arch, and also medulla oblongata. Mechanoreceptors, they can be within the bronchus, so within the upper respiratory tract. So metaboreceptors within the muscles. J receptors will be in the interstitium. So whenever in the lung fluid accumulates, these receptors will be stimulated. Stretch receptors on your chest wall muscles. Pulmonary vascular receptors in the pulmonary artery. If there is some variation up and down in pulmonary arterial pressure, these receptors will be stimulated. It's a very simple logic. So there is an input to a body. So something abnormal has happened. So it is picked up by these receptors. Now these receptors carry this impulse to a higher center for analysis. So what is the problem happening in the body? So it is carried by vagus and multiple unclear networks. And these are integrated in the brainstem, cerebral cortex, limbic system. So if you notice, whenever somebody is dyspneic, they will be having some panic. So they will be having some emotional disturbance. So they will be telling you that, so doctor, I'm feeling very difficulty to breathe. I'm getting this air hunger. So all this is carried out by the limbic system. So once the impulse is integrated in these areas, so from that, with the help of phrenic nerve, there will be an efferent output. So this will manifest as dyspnea. So this phrenic nerve is the one supplying your respiratory muscles. So what is the important respiratory muscle that phrenic nerve supplies? Yes. What is the important respiratory muscle that phrenic nerve supplies? Yes, it is your diaphragmatic muscles. So once the phrenic nerve is stimulated, so there will be increase in respiration. So there will be increase in respiratory rate, difficulty in breathing. So this is the important neurophysiological mechanism of dyspnea. You should know what are the receptors getting stimulated. So chemoreceptors, they will be stimulated by either less oxygen or more carbon dioxide. Hypoxia, hypercapnia. Mechanoreceptors, they will be stimulated by some mechanical stimulus. So if there is some bronchospasm or foreign body. So metaboreceptors, change in biochemical environment in the muscles. So if there is some increased lactates produced in the muscles. J receptors, because of fluid in the interstitium. So stretch receptors, pulmonary vascular receptors. So any one of the following can be stimulated. So that impulse is carried to your brain. In the brain, where it is integrated, brainstem, cerebral cortex, limbic system. So from there, there is your phrenic nerve, and ultimately it is going to give efferent output. So that efferent output will be in the form of increased respiration. So just 1 minute. Okay, now you have understood what is the mechanism of dyspnea. See, very simple. Now, what causes breathlessness? So, what are all the causes? So, you have understood the mechanism. So, now how those receptors will be stimulated? So, what causes breathlessness? So, what are all the systems in your body which can cause breathlessness? So, what are the causes? So, we can divide this into, yes, see, what diseases in your body can cause breathlessness? Yes, students, what are the diseases that can cause breathlessness? So, important systems taking part in gaseous exchange. So, one is your respiratory system. So, respiratory causes, there will be cardiac causes. So, either some problem in your heart, some problem in your lungs. So, very good. Anemia, yes. CVS, pulmonary, yes. Even metabolic causes. The patient might be having some ketoacidosis. So, that low pH can stimulate the respiratory center. So, anemia. So, whenever a patient with breathlessness reaches your hospital or OPD, these are the causes that you have to keep in your mind. So, can it be due to some respiratory disease? Can it be due to cardiac? Is it anxiety related? Or is there some respiratory muscle weakness? Is it due to anemia? So, anemia means less hemoglobin. Hemoglobin is responsible for oxygen carrying capacity of your body. And metabolic causes such as diabetic ketoacidosis, thyrotoxicosis, all this. So, now we have understood what is the mechanism of dyspnea, what are the important causes of dyspnea. Now, let us see out of these diseases which can manifest as acute breathlessness and which can manifest as chronic breathlessness or chronic shortness of breath. So, can anybody tell me what is meant by chronic shortness of breath? So, what is the timeline to call it as a chronic shortness of breath or chronic dyspnea? So, when do you call it as chronic dyspnea? Chronic dyspnea. So 6 months, no. Actually, chronic dyspnea means more than 1 month duration. So keep this in your mind. Chronic dyspnea means more than 1 month duration. So anything less than 1 month duration, it is called as acute shortness of breath. So this is from Harrison 20th edition. Chronic shortness of breath means more than 1 month duration or 4 weeks. Now let us see causes of acute shortness of breath. So what are the diseases that will manifest within minutes to hours? So patient will say that he was absolutely normal. Suddenly symptoms of breathlessness will start. So we have pneumothorax, pulmonary embolism, pulmonary edema, laryngeal edema, asthma exacerbation. So if you find a patient in the emergency department telling that, doctor, I was absolutely normal up to now. For the last few minutes or in the last 1 or 2 hours, I have developed shortness of breath. So what you should suspect? A pneumothorax, pulmonary embolism, pulmonary edema, some laryngeal edema due to some anaphylaxis or some other reason, asthma exacerbation. Yes, even foreign body aspiration can also be the reason. So acute pulmonary edema, myocardial infarction. Yes, acute pulmonary edema is also within minutes to hours. Now coming to what happens when there is dyspnea from days to weeks. We have pneumonia, ARDS, asthma, and other metabolic causes such as anemia, thyrotoxicosis, diabetic ketoacidosis. So these are the causes of dyspnea if it is within days to weeks. And one more important thing is many chronic processes such as COPD, asthma, cardiac failure, they can have some exacerbations intermittently that will also manifest as acute shortness of breath. So very important, when you find acute shortness of breath, these should be in your differential diagnosis. Am I dealing with any one of these conditions? Now coming to chronic shortness of breath. So can you tell me what are the causes of chronic shortness of breath? So which is extending for more than 1 month. Chronic shortness of breath. Yes. So what are the diseases that can result in chronic shortness of breath? Yes, COPD, anemia, very good. ILD, very good. Yes. Any other diseases? Anemia, good. Heart failure, true. Yes, carcinoma. Yes, carcinoma. Okay, let us see the list. So, list of diseases which generally causes chronic shortness of breath. Pleural effusion is one important cause. Chronic obstructive pulmonary disease, ILD, neuromuscular diseases, anemia. Yes, pulmonary hypertension, few pulmonary vascular disorders. So, valvular heart disease, heart failure, anemia. So, all this will cause chronic shortness of breath. So, this is few list of conditions that you should keep in mind whenever you are dealing with dyspnea. So, first find out, is it acute or chronic. Now, coming to system wise, what are respiratory causes of shortness of breath? Let us see by mechanism. So, why will these diseases cause shortness of breath? So, respiratory system is responsible for gas exchange. So if there is some abnormality in gas exchange, so your alveoli are filled with secretions, pneumonia, pulmonary edema, or your pulmonary artery is blocked. So pulmonary artery is the one supplying blood to the lung where gas exchange happens. And aspiration, some aspiration pneumonia, all this interfere with gas exchange. Then increased airway resistance. So your airway, if it is having normal diameter, air will flow properly. Now the diameter has decreased, airway resistance has increased. So asthma, COPD. Then there is some difficulty in expansion of the lung. See, if your respiratory muscles become weak, your lung cannot expand. ILD, your lung is becoming very stiff. So stiff objects cannot stretch properly, and there is a pleural collection. So this pleural collection will compress the lung, not allowing it to expand. So these are all the respiratory causes. and most of these mechanisms will overlap. Now coming to cardiac causes. So already we have discussed a few cardiac causes. So let us see the mechanism. So in cardiac cause, the problem is your heart is not functioning. So the blood will stay in the pulmonary circulation. It can come into the alveoli. So there will be stimulation of these J receptors that can result in shortness of breath. So these are the important causes of shortness of breath with respect to cardiovascular system. So pulmonary edema, acute valvular disease, myocardial infarction. So other important causes: anemia, metabolic acidosis, thyrotoxicosis, fever, infection, some progesterone. So this fever, infection, aspirin, progesterone, all this can directly stimulate the respiratory system. Now in this given patient, what might be the reason for breathlessness? So in this given patient, so patient is having chronic history. She is not a diabetic, not a hypertensive. She is not having any fever. She is not having any orthopnea. So I feel that because there is no fever, so it might not be an infective cause. Because there is no significant orthopnea, there is no hypertension, so probably no chest pain, palpitations, syncopal attacks. So it may also not be CVS cause. So I have done a CVS examination. Her JVP is normal, pulse is good, BP is good, S1, S2, heard no murmurs. So now I feel that her CVS is good because she is not having cardinal manifestations of cardiovascular system pathology. Now somewhere I feel that this is due to respiratory problem. So now I'm going for patient's respiratory examination. See, anemia might be, so there is no pallor. So I have seen her eyes, so there is no pallor. So anemia is also excluded. She's not having any thyroid disorders, no diabetes, no hypertension. So I have also excluded metabolic causes, and she is not having any weakness of respiratory muscles, and her respiratory effort is good. I have excluded neuromuscular causes. So now the respiratory examination. Say everybody kindly listen to the findings. I want you to tell me what is the probable thing happening in this patient. So when I have examined the trachea, it was slightly towards the right. It was towards the right, and chest wall expansion is decreased on the left. So very important. So trachea towards the right and expansion is decreased on the left, and percussion is normal on the right side. So what is the normal note on your lungs? So if I percuss on your lungs, so what is that note called as? Yes, so it is a normal resonant note. But here I am getting a stony dull note in the left side on the mammary, infraaxillary, and infrascapular regions. And when I auscultate, there is decreased air entry and decreased vocal resonance on same area. Now, with this background, can you tell me the first question answer? So, what is the diseased side in this patient? So, which side patient is having disease? Is it right side or left side? Is it right side or left side? Yes, what is the diseased side? It has to be left side because chest wall expansion is decreased on that side. Now, we have seen there is some dull note on percussion. What are the other causes of dull note on percussion? Yes, other causes of dull note on percussion. So, what are all the diseases that can cause dull note on percussion? Yes, dull note on percussion. Yes, apart from pleural effusion. Very good. Consolidation, pleural effusion, collapse, and next important thing, some mass in the lung or the pleural space. So very important question in your Viva for final year students. They will ask you, what are the causes of dull note on percussion? So first is pleural effusion, collapse, consolidation, lung or pleural mass. Now coming to the next question, what might be the cause of dull note in this given patient? Yes, what might be the cause? Now we have understood disease is on the left side. Trachea is towards the right side. So it means a disease from the left side is pushing the trachea to the opposite side. So it can be a pushing lesion. So we are having two important pushing lesions. So where there will be contralateral shift of the mediastinum. One is pleural effusion. Can anybody tell me what is the other pushing lesion? Yes, pushing lesion apart from pleural effusion. Other pushing lesion. See, consolidation will not cause the shift of mediastinum. Yes, pleural effusion will cause. Any other. So mass, if it is very massive, it will cause, but very common. Yes, pneumothorax. So there are two important pushing lesions. One is consolidation, other is pneumothorax. So how did I exclude pneumothorax here? Why it is not pneumothorax here? Why this patient is not having pneumothorax? Yes, because in pneumothorax you will get a hyperresonant node. So this is left-sided diminished breath sounds with tracheal shift to opposite side and dull note. This is suggestive of pleural effusion. So now we have understood in both pleural effusion and pneumothorax, there can be a pushing lesion. But how to differentiate? Percussion. Percussion will show a definite stony dull note in pleural effusion. Now, how do you exclude other common pathologies causing decreased air entry? So now we have understood when you put a stent in this patient, there was reduced air entry. So can you tell me what are the causes of reduced air entry into the lung? What are the diseases? One is mass, yes. So what will cause decreased air entry? What will cause decreased air entry? So important causes of decreased air entry. So obstruction, yes. So what is that obstruction within the bronchus called as? So you should call it with the medical terminology collapse. Very good. Pneumothorax, pleural effusion, mass, collapse will cause decreased air entry. Yes, severe COPD, asthma, fibrosis will also cause decreased air entry. Important causes of diminished air entry. Once again, this is also an question asked in your Viva. So, what are the lung diseases responsible for diminished air entry? Pleural effusion, collapse, pneumothorax, severe asthma, and COPD. So, now why this is not collapse? So, why can't you consider this as collapse of lung? Why it is not collapse of lung? In collapse also you are getting a dull note. In collapse also there is a diminished breath sound. But this is not lung collapse. I am saying this can be pleural effusion. So why it is not lung collapse? Can anybody tell me why this is not lung collapse? Why I am thinking it as pleural effusion? Very good. Tracheal position. See, collapse and fibrosis are actually pulling lesions. If at all there is right-sided fibrosis or right-sided collapse, trachea will be pulled towards the same side. But here clearly, left-sided disease, trachea to the opposite side. So it means it is a pushing lesion. It means it is a pushing lesion. So I have excluded collapse. So what pathologies can cause increased sound conduction? See, up to now we have discussed what pathologies will decrease sound conduction. Is there any lung pathology that can increase the sound conduction? Yes. What pathologies can increase the sound conduction? Very good. Consolidation. Yes. What is responsible for consolidation? What is the disease causing consolidation? Yes. It is pneumonia. So what will cause increase? See, pneumothorax also there will be absent to diminished breath sounds. See, pneumothorax absent to diminished breath sounds. See, your lung is responsible for producing breath sounds. Now from the pleura, air is compressing your lung. So whenever your lung is getting so much compressed, where will breath sounds be produced from? So increased sound conduction, also called as bronchial breathing, one condition that is consolidation due to pneumonia. So pathology is increasing sound conduction, pathology is decreasing sound conduction, we have understood. Now what is your provisional diagnosis? Provisional diagnosis. So in your final exam, also clinical examination, the examiner will expect you to tell the diagnosis in these components. I want the anatomical component, pathological component, etiological component, complication if any. Yes. So we have discussed the case. We have seen the clinical findings. We know where the disease is, what the disease is. Now put it in a pattern compatible for your examiner. So what is your provisional diagnosis? Yes, provisional diagnosis. So anatomical, which part of the patient's body is involved here? It is the left side pleura. So anatomy is left side pleura. Pathology, what has happened to that pleura? There is accumulation of fluid. So left sided pleural effusion. Now etiological, what might be the cause of pleural effusion in this patient? Say, because it is an unilateral pleural effusion, that too on the left side. So generally it may not be due to any systemic cause. So we have to entertain two common causes. So most common exudative cause of pleural effusion is tuberculosis, and her age, it is more than 60. So it can be also even malignant etiology. So somebody is putting symptomatic consolidation. See, there should be pneumonia. So what are features of pneumonia? Patient will have fever. So pneumonia infection, patient will have fever. So you cannot call it a pneumonia effusion. So pancreatitis, so she is not an alcoholic and not a diabetic, no abdominal complaints. So left side effusion due to pancreatitis is unlikely. So this is a left-sided pleural effusion. See here, we have provided the anatomical diagnosis, pathological diagnosis. So etiology, still it is not evaluated, but probability of tuberculosis or malignant. So because of age factor and she living in our country. And complication, if any, so patient is having significant shortness of breath. So if it, you can call it as with respiratory distress. So this should be the complete diagnosis. So left-sided pleural effusion with probable tubercular or malignant etiology with respiratory distress. So what test you will carry out to confirm your clinical suspicion? Now I am feeling it as pleural effusion. So what should be the test? Yes, what should be the next test? Yes, what will you do next? You think it is pleural effusion. What will you do next? Yes, so you cannot just go into paracentesis because that is an invasive procedure. First, see whether your diagnosis is correct or wrong. Go with the simple examination of chest radiology. So we go for a chest X-ray. So chest X-ray. So initial investigation in this patient is chest X-ray. It will be a chest X-ray. Yes. So chest X-ray was done. So what does her chest X-ray show?
Now, finally, we have a radiology comment here. And radiology plays a big role in pulmonary medicine. So, chest x ray is the key here first. And anybody wants to comment on the chest x ray?
Yes.
So we can see a lot of messages and comments now.
Yes, yes. So they have first identified it as left-sided pathology. Yes. Then describe the pathology on the chest X-ray. What do you find?
So I think most of them are able to get it that there is a opacity on the left side. It's a homogeneous opacity. Now, can all of you understand and tell me why it is homogeneous? Like, if it was having some air bronchogram, then what would you think? If it had air bronchogram, then what would you have think? So this is homogeneous opacity, totally white. So if it had air bronchogram, then you would have thought of consolidation. But this is totally homogeneous. And second thing that you notice here is that we can also see that CP angle is obscured. The diaphragm is obscured, the CP angle is obscured. That tells us that the dependent area of the chest and the pleural cavity is obscured. And so, what would go in the dependent area is the key here. What would go in the dependent area? What would show the Ellis curve or the meniscus line that I'm highlighting? And what would push the trachea to the other side? So, on the X ray, we are able to confirm the entire of the clinical thing. And I'm sure most of you are able to write it correctly that we are looking at pleural effusion. So, we are looking at pleural effusion. So, this was the question. The second question is that what are the diseases which will cause unilateral white lung field on a chest X-ray? What are the diseases which will cause unilateral white lung field on the chest X-ray? What do you think? Other than effusion, one effusion is one which will call opacity. What else will cause unilateral white lung field on the chest X-ray? So fluid is one, consolidation is one, yes.
Yes.
Anything else? Collapse is one, very good. Mass. So I think you have been able to give us almost all of the differentials that we were looking at: consolidation, collapse, pleural effusion, large lung mass, pneumonectomy. These are classic causes of unilateral lung fields. And here you can see that consolidation will not cause the shift of the trachea, collapse will pull, pleural effusion will push. And that is how we've been approaching the entire discussion so far. Okay. Now, let's take you to the next question now. What is the amount of pleural fluid required to identify on these investigations? Chest X-ray PA view, lateral decubitus, ultrasound chest, CT chest. I want you to mention for each of them in this very order. How much fluid do you need to see in chest X-ray PA view, in a lateral chest X-ray, in lateral decubitus, ultrasound chest, and CT chest?
So
Okay,
whenever a
so we
pulmonologist writes a chest X-ray, it is generally chest X-ray PA.
yeah. So I think we have some good answers by students who have given it.
Yes, sir.
So let me just let's see more answers that what you're saying, so that before we tell you the answers, you have the perspective. Okay. So usually what we say is for a chest X-ray PA view, we need 150 to 200 ml of fluid, that most of you were correctly answering for chest X-ray PA view. But what happens is, on a lateral view, even 75 ml of fluid can be detected because the posterior CP recess is deeper than the anterior CP recess. So on a lateral view, we can see the anterior posterior separately, and we can see the posterior CP recess will be blunted first. So for the lateral view, it is 75 ml. For lateral decubitus, when you make the affected chest dependent, even 15 to 25 ml fluid can be detected. For ultrasound chest and CT chest, approximately even less than 10 ml can be detected by these investigations. These are very highly sensitive investigations for pleural fluid. So I think most of you were close. So now let me put Dr. Bharat into the question again, and the question is,
How do pleural
how do
effusions
pleural
develop?
develop?
So why is a pleural effusion happening? Now we have clinical data, radiological data. So we have found out it is pleural effusion, which is more sensitive. So sensitive, if it is asked as a bedside investigation, ultrasound. They ask you on the whole, more sensitive CT test is very good. So how do pleural effusion develop? The types are transudate and exudate. So how do they develop? Transudative effusions develop when there is some difference between hydrostatic pressure and oncotic pressure. You must be learning in your pathology. For fluid to accumulate anywhere, either there should be increased hydrostatic pressure or decreased oncotic pressure. Transudative effusions, a systemic cause responsible for, yes. So am I audible? Yes or no? Any audio issues? Yes. Now?
I think now it is better. It's better now.
Okay. So there are two types of effusions. One is transudate, exudate. Transudate only due to changes in hydrostatic and oncotic pressure. Exudate when there is some active pleural inflammation, increased capillary permeability, it will cause effusion. So whenever you find a pleural effusion, so the next step is I need to evaluate what is the cause of pleural effusion in this patient, so that my treatment will be guided according to that. So first I should know how pleural effusion develops. So what is transudate? What is exudate? Transudate, no damage to pleural membrane, only difference in the hydrostatic and oncotic pressure. Exudate, direct damage to the pleural membrane and exudation of particles, infectious materials into the pleural cavity. So this is the important mechanism of pleural effusion, and also because of lymphatic blockage. Now, how do you investigate her pleural effusion next? Now you found out on the chest X-ray there is pleural fluid. So what will you do next? Yes, clinically it is pleural effusion. Radiologically it is pleural effusion. Now how do you investigate further? What will you do next? Yes, what is the next thing that you should do?
The question now is that what do you do now? And please, type your answers so that we can see how you are proceeding as a doctor and you are managing the patient. What will you do now?
Now same patient has come to you with her chest X-ray and with the same clinical findings. So what will you do next? Yes. So you want to put a needle and you have to see what is the type of fluid. Very good. So now I wanted to know whether it is transudate or exudate. So for that I should have pleural fluid analysis. So she requires aspiration and analysis of fluid to distinguish the effusion types. But this patient was having some moderate to massive effusion, and she was also complaining of shortness of breath. So I have decided, rather than taking 10 to 20 ml, let me give her some relief. So I proceeded for therapeutic thoracentesis. So how is pleural aspiration performed? You can see this is myself doing a pleural aspiration. So for one of my patients, so this is the position that we do therapeutic thoracentesis, a 20 cc syringe, 3-way cannula, a large bore needle, and also an IV set. So let us see the steps. So how do you do pleural effusion? How do you tap a pleural effusion? So clinically, I should identify the site with percussion. If there is very less fluid, I don't want to damage the lung, I go for ultrasound guidance. So if effusion is small, I go for the ultrasound guidance. So generally, wherever there is maximum dullness, so that intercostal space you can select. Or if you have an ultrasound probe, so you can go to the point where there is maximum fluid shown by the sonologist. So aseptic technique and local anesthetic is infiltrated. So for diagnostic tap, only 21 gauge needle is inserted into the pleural space. So according to the world guidelines, let it be for diagnostic or therapeutic, we used to go for 5th to 7th intercostal space infrascapular area. So this was according to the world guidelines, 5th to 7th intercostal space infrascapular area. According to new guidelines, you put an ultrasound probe wherever there is fluid in excess, you can put a needle and aspirate. And very important thing is, if these are your two ribs, and in between the ribs there is intercostal space, so needle should be inserted here, so in the lower part of the intercostal space. So never put your needle underneath the rib, because underneath the rib there will be neurovascular bundle. So if you puncture here, there can be bleed. So make sure you are inserting the needle on the superior surface of the lower rib. Or in simple words, if there is an intercostal space, where should I go? Should I go in the upward portion or the lower portion? So I should go in the lower portion. Very important. I have seen so many putting the needle inadvertently and causing some hemorrhagic tap. So very important, if this is the intercostal space, make sure your needle is going in the lower part of intercostal space. So I have performed an therapeutic tap, and about 1 liter of hemorrhagic fluid was aspirated and chest X-ray was repeated. So now, what do you find in this chest X-ray? Post aspiration.
So this is a post aspiration chest X-ray given to you. Now you have to tell us what has happened in the post aspiration now. You have to look at the X-ray and tell us what has happened now.
You can just compare with the previous X-ray. What was there here? What has decreased here?
So let me show them the previous X-ray first. And this was the previous X-ray.
So now I have aspirated fluid. Can you find any additional finding here that will help you to in your evaluation? Something new here, which was not found previously.
Yeah, definitely the opacity has decreased, the fluid has decreased. That is correct, and we even know it clinically also. He has aspirated 1 liter fluid. The
And she
lung
is
has
also
re.
feeling comfortable. Yes.
Anything else you see other than that? We can have. We have been able to see so much. Now, the point that we wanted to make here is, although the lung has re-expanded, the effusion has reduced, but you can see now we can have some opacity in the lower zone is visible now, which we did not see initially because of the massive effusion. In the initial X-rays, we had no opacity in the lower zone. Now the lung has re-expanded, but there is a opacity in the lower zone, which we do not know right now what is there. But the question that has been asked to the radiologist by the pulmonologist is that there is hemorrhagic effusion, and one of the causes of hemorrhagic effusion is malignancy. And now we are suspicious, as a radiologist, now on the chest X-ray we are suspicious that the lung has re-expanded, but why there is this irregular speculated kind of opacity here, but the effusion has reduced definitely and the lung has re-expanded. So this is the chest X-ray findings that we think right now, and we send back the patient to the pulmonologist, and we tell him that although the lung has expanded, but there is some doubt that we now are able to see.
Now
And
this was
this
the effusion aspirated. So what is this? So you can see a hemorrhagic pleural effusion. So can you tell me what are the causes of hemorrhagic pleural effusion? So what are all the causes of hemorrhagic pleural effusion? Yes, causes of hemorrhagic pleural effusion. This was from the same patient. Yes, one is hemothorax. Good. Apart from that, malignancy. Yes. So you should able to say at least 5 causes. So in your exam, when they ask you at least 5 common causes. Yes. So malignancy, it can be primary or secondary. Yes, trauma. Good. Can tuberculosis cause hemorrhagic pleural effusion? Yes. Can tuber? See, traumatic tap, we have taken sufficient precautions. And when I was aspirating, so I felt no resistance. So it's not the blood, it is a hemorrhagic pleural effusion. Yes, tuberculosis can also cause hemorrhagic pleural effusion. The patient is having some bleeding diathesis. He is on some anticoagulant therapy, lymphoma, leukemias. All this will cause hemorrhagic pleural effusions. So when they ask you in your exam, if there is hemorrhagic pleural effusion, what are the important causes? So this is the list of causes.
And I think Bharat has given you a very very important question. This is often asked in your Viva Voce as well as in your MCQ exams. So make sure that you name all of them out.
Yes. So now I got this fluid. I sent it to my pathologist, microbiologist, and also biochemistry department. I have advised some set of investigations. So let us see the pleural fluid analysis report. So these are the set of investigations. So protein was on the higher side, LDH higher side, cell count 1500 per mm cube, lymphocyte predominant, background is showing many RBCs, ADA adenosine deaminase 40 international units. So glucose slightly less. See, normally in pleural fluid, glucose will be about 70 to 80 mg%. Here it is 40. Less than 60 is called as low glucose pleural effusion. Gram staining, no bacteria seen. AFB sign negative. So my pathologist asked me 2 or 3 days time. So the cytology report is awaited. Now by seeing this, what might be the possible diagnosis? What does the pleural fluid analysis is suggest you of? Yes. So first of all, tell me, is it transudative effusion or exudative effusion? Transudative effusion or exudative effusion? Definitely exudative effusion, because the proteins and LDH are on the higher side. So next I'll tell you what is transudate and exudate. So lymphocytes are predominant, but don't go it as tuberculosis, because other diseases also can have lymphocyte predominant. So ADI is also not on the higher level. So higher level is generally more than 40 international units. So it is in the border, and glucose is less. So up to now, I got this as the diagnosis. High protein and LDH, it is a exudative pleural effusion with low glucose. So I hope, let me once again tell you, a patient with shortness of breath, I found out it to be left pleural effusion. I aspirated the fluid. Fluid analysis is showing exudative pleural effusion with low glucose. Still, I did not find the exact etiology. Now, to find the exact etiology, first let us see what is transudate, what is exudate. So now, how to differentiate transudate and exudate? So can anybody write down this criteria? This is called as Light's criteria. Yes. So this is the Light's criteria. You can notice. You should see the ratio of pleural fluid and serum protein. Pleural fluid LDH by serum LDH. So if these ratios are higher, it means there was damage to pleural membrane and proteins and LDH has leaked into the pleural space. So if these ratios and values are high, it is an exudative pleural effusion. If it is less, it is transudative pleural effusion. So SAG is for ascites, Light's criteria is for pleural effusions. So normally the proteins will be less, the ratio of serum and body protein, I mean serum proteins and pleural effusion proteins, the ratio will be less. So suppose if your body protein is 6, in the pleural fluid it will be somewhere about 1 to 2 gram percent. But here the ratio will be higher. If your body's proteins is somewhere 6, in the pleural fluid you will get 4, 5. You can see in this patient the pleural fluid protein ratio and the LDH ratio is definitely higher. So this is an exudative pleural effusion. Again, this is a commonly asked viva question. So how to differentiate transudate exudate? Now the common causes of transudate and exudate: cardiac failure, cirrhosis of liver, nephrotic syndrome. And in exudate, we have infections, most common infections, and malignancy, inflammation, connective tissue disorders, trauma, GI cases, GI causes such as liver abscess, pancreatitis, all those. Now my question is, out of this, what is most common cause of pleural effusion worldwide? Most common cause of pleural effusion worldwide. What is the most common cause of pleural effusion worldwide? Most common cause of pleural effusion worldwide. The rheumatoid arthritis is a rare cause, not infection. Yes. Cardiac failure. Yes. But if they change the question like this, most common cause of exudative pleural effusion worldwide. Exudative. If they just ask only about exudative. According to 20th edition Harrison, most common exudative cause is tuberculosis. Most common cause overall is cardiac failure. So these are the two questions that you should know. So now what are the causes of low glucose pleural effusion? Causes of low glucose pleural effusion. So TB is a rare cause. I want common causes of low glucose pleural effusion frequently asked in AIMS PGI. Low glucose pleural effusion. See, whenever there is an active infection in the pleural cavity, glucose will be consumed. So pus in the pleural cavity, first cause, empyema. Malignant cells, they have more metabolism, they consume the glucose. And in rheumatoid arthritis also, there can be low glucose pleural effusion. So these are the three important causes. So when you find a low glucose pleural effusion, malignancy, rheumatoid pleuritis, empyema. Now putting the case scenario, elderly female, exudative pleural effusion, hemorrhagic, low glucose. So she is not having any infective signs. So empyema is ruled out because there is no pus. And she is not having any features of connective tissue disorder. So rheumatoid pleuritis is also not a possibility. One possibility here is malignancy. So before that, let us see some important features of TB effusion, because most common exudative is tuberculosis. So what are the features suggestive of tubercular effusion? So I want you to type. So being in India, so this is our national disease. So you should not forget the findings of tubercular pleural effusion. I want everybody to type What do you see in TB pleural effusion? Is it transudate or exudate? First question. Is it transudate or exudate? Tubercular pleural effusion. It is an exudative pleural effusion. And which cells are high? Is it lymphocyte predominant or neutrophil predominant? Answer should be yes, lymphocyte or neutrophil. Lymphocyte or neutrophil. It is a lymphocyte predominant effusion. And what are the markers of TB effusion? There are two markers. What are they? One is ADA, adenosine deaminase, and other is interferon gamma. So you should answer this question even if somebody wakes you from sleep in our country. What do you find in TB effusion? Exudative, lymphocyte predominant, high ADA, and interferon gamma. But if they ask you, what is the gold standard method? See, for any infection, gold standard method is identifying the organism in the lab. So under your microscope or in the microbiology lab. So either culture of pleural fluid, but culture of pleural fluid, the bacilli will never be more in the fluid, they will settle in the tissue. So best is taking the pleural biopsy and sending it for culture. So if they ask you gold standard for TB pleural effusion is, so majority of the bacilli will not be floating. You can see in this image, they are settled in the pleural tissue. So you can do a thoracoscopy or needle biopsy, take the pleural tissue and send it for culture. So if they say there is TB bacilli grown, or if you identify on CBNAT, CBNAT is a molecular assay, cartridge based nucleic acid amplification test. So if they say there is TB bacilli present, so that is gold standard investigation. So if they ask you how will you investigate TB pleural effusion, ADA and interferon gamma, lymphocyte, exudate. But if they ask you gold standard, you should identify the TB bacilli. So for that, best is pleural tissue for culture or CBNAT. So these are the features of tubercular pleural effusion. Now, if you neglect a pleural effusion, what are the complications of pleural effusion? So what will be the complications of pleural effusion? I want the answers. What will be the complications of pleural effusion? Yes. So I'm just leaving the fluid like this. I'm not aspirated. I have not evaluated. What will happen? What will happen? What are complications? So one is, instead of you can call it as a pleural thickening. Good. So empyema, fluid can get infected. Very good. So pleural thickening, lung will not expand. Yes. Respiratory distress. Very good. Very good. And if at all there is some tubercular infection in the pleural space, it can easily go into the adjacent compartment, such as the pericardium, peritoneum. Yes, these are the important complications. Pleural thickening. So the fluid, later on the fibroblast will accumulate. So it will form a thick peel around the lung. So lung will not expand permanently. If it gets infected, pus will be formed. Pus in pleural cavity, empyema. Infection can spread from the pleural cavity, adjacent compartment. We have the mediastinum here, peritoneum here. It can easily go into those areas. And if the fluid is so much, it can compress the great vessels and it can result in cardiorespiratory embarrassment as a result of massive pleural effusion. Now the next question is, this is also for your Viva. So what causes predominantly right-sided pleural effusion and predominantly left-sided pleural effusion? So in pleural effusion also there is side preference. So you can have a look at this list. See, right side liver is there. So when there is a liver abscess, it can rupture. Meeks syndrome, ovarian tumor with ascites and pleural effusion. And pleural effusion due to liver disease, cirrhosis of liver. If there is a right-sided subphrenic abscess, right-sided subphrenic abscess, and congestive cardiac failure, heart failure also, the pleural effusion starts first on the right, then it can become bilateral pleural effusion. So try to know the predominant right-sided effusion. Now coming to the predominant left-sided effusion. Pancreas is on the left, acute pancreatitis. Esophagus is also slightly towards the left. When esophagus ruptures, so with that force, even the pleura can be ruptured and esophageal contents will be emptied into pleural cavity. So Dressler syndrome, it is a hypersensitivity reaction to the necrosed myocardium. So that also happens on the left. And left-sided subphrenic abscess. So these are the important conditions. Now I got the cytology report of this patient. Her cytology report, malignant cells suspicious of adenocarcinoma. So it is not still confirmed, but my pathologist is saying that there is a suspicion for adenocarcinoma. So now I feel this is some adenocarcinoma related pleural effusion. Now what should be your final diagnosis? So you got the clinical history, radiological interpretation, biochemical, microbiological, nothing significant, biochemical exudative, and cytological report. So what is your final diagnosis now? Yes. What is your final diagnosis? So what might be the final diagnosis? So this is a pleural effusion. So what might be the reason? So it is a left-sided malignant pleural effusion. So the diagnosis is left-sided malignant pleural effusion of adenocarcinoma type. Now my question is, what is the most common lung cancer worldwide? Histology. What is the most common lung cancer histology worldwide? Worldwide. Yes. What is the most common lung cancer histology worldwide? So it is not SCC. It is not SCC. What is most common? Most common is adenocarcinoma. Most common is adenocarcinoma. Now, what is the next step in evaluation? Now, you have identified pleural effusion suspicious of malignant cells. What do you want to see? Already you have noted that there is some suspicious lesion on the chest X-ray. Now, you want to see it better. So, what will you do? What is next step in evaluation? Yes? What will you do next? What will you do next? Yes. So I will go for contrast enhanced CT. I will go for contrast enhanced CT chest. So I'll see what exactly is the nature of the lesion. So I have taken a CT chest. What do you identify now?
So you have to comment on the CT finding now. What is the CT finding here? Anything that you can see abnormal on the CT scan? Because we've seen the X-ray and we had some suspicion on the X-ray, if you remember. Okay, let's see if you can tell. So this is not split pleura sign, but a split pleura sign will be seen in empyema. This is not empyema. There is a intraparenchymal lesion. Yes, yes, correct. So I think most of you are able to correctly identify that on the left side you have a mass-like lesion with speculations, irregularity, and we already know that there was malignant pleural effusion. Now we can see in the lung, in the lower lobe, we have a mass. So the CT is confirming the diagnosis for us, and we know we are dealing with a malignant pleural effusion with a tumor. So let me ask Bharat to give the further remarks.
See, my pleural fluid analysis report was suspicious of malignancy. I mean, suspicious of adenocarcinoma. See, nowadays, if I want to treat lung cancer, I should know the exact I should know the exact histology, and moreover, I should have good tissue so that I could send it for immunohistochemistry and also for markers such as EGFR, ROS, ALK, all those. So for that, I need to take a better tissue. So I have explained regarding biopsy to the patient. So patient was explained the need of biopsy of suspicious lesion. So she was in the admission, and they were deciding regarding biopsy to be undergone. Meanwhile, after 4 days, patient developed again shortness of breath. Now, what might be the reason? Say, I have aspirated the fluid. I have found out it to be malignancy. So they were still in the hospital, and after 4 days, she developed shortness of breath. So, what might be the reason in this patient? Yes. So she is under your admission. What might be the? It's not immediately. It is after 4 days. What might be the reason? Yes, accumulation of fluid, re-effusion can be one cause. Yes, air entering into pleura when we are aspirating. So you cannot call it as pneumothorax because already there is some fluid. Hydropneumothorax. Anything else? Anything else? So hospitalized patient, sudden shortness of breath. That too patient with malignancy. So in a malignant patient, the clotting mechanism will behave very differently. Yes, yes, very good. So pulmonary embolism can also be a possibility. See, you should have these in the differentials. It may not be pulmonary embolism, but still, at least these should be the differential. Is it reaccumulation of fluid, or is it hydropneumothorax, or can it be pulmonary embolism? Because adenocarcinoma has highest hematological paraneoplastic syndromes. Now, a chest X-ray was taken. So, what do you find again? So, this was the repeat chest X-ray again.
Now you have a repeat chest X-ray, and I think the answer is actually obvious to you. Now, do you think this is pulmonary embolism? Do you think this is a reaccumulation of fluid, or do you think this is hydropneumothorax out of the clinical possibilities that we had? Now you can see the X-ray has become same as before. Just if you remember the first X-ray that we saw, it has become same as before, and you can see there is rapid reaccumulation of fluid, which is again one of the features that you find in malignant diffusion, because it is because of malignancy. So even they have done a therapeutic tap, he has taken out 1 liter of fluid, but now you see again a rapid reaccumulation of fluid. And you can see how chest X-ray, although today we sometimes as radiologists people are looking more and more at CTs and all, but chest X-ray plays an integral role in follow-ups and to finding what is happening and to be able to tell us.
And
Now,
moreover, as clinicians' perspective, chest X-ray is very economical. I cannot ask
yeah.
the patient to repeatedly go for CECT chest every 3 or 4 days. And radiation exposure is also very minimal, economical, and very effective bedside diagnostic tool for a pulmonologist is chest X-ray and ultrasound chest.
And any
So,
radiology or pulmonology residents listening to us right now, that sometimes you're trying to learn CT etc., but you're ignoring chest X-rays. Don't ignore chest X-ray. Chest X-ray in a hospital is the, I think, the highest number of investigations that are done in radiology department is a chest X-ray, I think.
yes, sir. Now, this patient, it is a left malignant pleural effusion with recurrence of fluid. Now, what are the treatment options that I should discuss with the patient? See, nowadays, whatever knowledge you have, you should communicate with the patient and make sure patient is comfortable before you are doing a procedure. So, what are the options that I should discuss with this patient now? Yes. So, chemotherapy, good. So, but chemotherapy, now the patient is in respiratory distress, rapid reaccumulation. You cannot start it immediately. So, thoracostomy, pleurodesis, yes, pleurodesis is a good option. Chemoradiation, okay. Now, there are three options that I can give to a patient. So, repeat aspiration. So, if the patient is not willing for an invasive procedure such as ICD insertion, so I can just put a needle and aspirate the fluid. Or I can go for ICD insertion and pleurodesis. If the patient is not affordable, or if there is no thoracoscopic procedure available. But if they ask you what is preferred, put a thoracoscope into the pleural cavity, visualize the pleural cavity, drain out all the fluid, take biopsy, adequate tissue, and do a pleurodesis. So, what is meant by pleurodesis? You are going to add some chemicals and make sure the pleura becomes adherent. So this is the procedure. You can see my thoracoscope is going inside, some hemorrhagic fluid, and you can see the involvement of pleura there. So all those hyperemic areas. So I have taken a thoracoscopic biopsy. I got adequate tissue. Now my pathologist, he has confirmed that this is metastatic deposits of adenocarcinoma. So there is one saying in malignancy: when tumor is rumor and cancer is your answer, tissue is the biggest issue. So get the tissue, you will get the diagnosis of malignancy. So by doing thoracoscopy, I have taken the tissue, then I have put some talc there. So I have done fluorodesis with talc. So after this, a chest X-ray was repeated again after 2 days. So this was the post-procedure chest X-ray.
Now, in the post-procedure chest X-ray, you can again see that now you can actually notice that there is a ICD tube on the left side. This is how it looks like, and there is good expansion of the lung, which we can appreciate in the post-procedure X-ray.
So post-procedure chest X-ray, there is good expansion and the drainage of fluid has also stopped. So lung has expanded and drainage has stopped. It means my procedure was successful. So I removed the ICD tube and I started the chemotherapy. So we went for, we were thinking about starting chemotherapy for adenocarcinoma. So what happens if the lung is not expanding? So what are the causes of poor expansion of lung? Yes, what are the causes of poor expansion of lung? So when will lung not expand even after putting an ICD? So this is very, very important for residents out there. So what you should suspect? You have put an ICD, but lung is not expanding. What you should suspect? Yes. So one is intrabronchial obstruction. So the mass might be in a bronchus, and even if you drain the fluid, your lung is not expanding. And second important thing, yes, ICD tube placement error always to be taken. So I'm telling you what pathology is in the lung. So one is active infection. So whenever there is active infection, there will be continuous production of the fluid. Bronchopleural fistula. So there is a connection from the bronchus into the pleural cavity. Always air is seeping into the pleural cavity. So there will be no proper expansion of the lung. And already a pleural peel was formed. So your lung is already covered with a pleural peel. So even if you put a tube, your lung will not expand. So these are the causes of poor expansion of the lung. Now they follow up. After 3 days, the ICD was removed and patient was advised for a PET scan. Now can you tell me what is the advantage of PET scan here? Yes. So what is PET scan? Yes, peel is fibrosis. PET scan. What is the advantage of PET scan? Yes, it is a metabolic scan and it can identify areas of high metabolism. So usually in malignancy, if you find some positive areas with high metabolism, that can be metastasis. As it was a malignant pleural effusion, it is generally stage 4 disease. So in the tumor staging, whenever you find a lung cancer with some malignant pleural effusion, stage 4. So stage 4, you cannot do surgery because to do surgery there should be a localized tumor. So we usually do medical management with chemotherapy. So for medical management with chemotherapy, so in our hospital we have referred it to an medical oncologist. So most common site of metastasis is the brain. Now coming to the case analysis, so what we have actually done, what we have actually learned here. So there was an elderly female presenting with chronic shortness of breath. We have discussed the mechanism of shortness of breath, the causes of acute versus chronic, how will a respiratory disease cause, what are the cardiovascular causes, metabolic causes. When evaluated, was found to have left pleural effusion. We have understood what are the examination findings in pleural effusion, both radiological, clinical. She underwent pleural aspiration. We have seen the procedure of pleural aspiration, and the reports were suggestive of malignancy. We have understood what is transudate, what is exudate, and how will a malignant pleural effusion appear, and what are the treatment options for malignant pleural effusion. So, just a therapeutic aspiration, ICD insertion with pleurodesis, or preferred is thoracoscopic drainage with pleurodesis. So she underwent the preferred method, and after all the diagnosis work is done, she was referred to a medical oncologist for chemotherapy. So this
I
was
think the
what
most
we have done.
important thing that we wanted the students to learn was to how to think. And the key here is that you had the specialist with you telling you that okay, what is the next step, and you could find out how to go about things. Because today the most important thing is not making a diagnosis or like telling the treatment or MCQ. The idea is how you approach the patient, and you learn how to go step by step till the time we could reach to the diagnosis and go to the further management part, and how to kind of you saw how sir was always fine tuning the work that he was doing. And I think this is the key today in all your MCQ exams also. Gradually the exams are becoming, not, they are going away from the most common site and least common variety. They are going towards how you will proceed further, what will you do next. And once you start learning this kind of thing, you start enjoying medicine, and when you enjoy medicine you score better in the exams. And that is the purpose of this clinical case challenge. If you enjoy this, please share the video with the on the WhatsApp groups of your colleges, so that other students can also participate in the next episode of this clinical case challenge. Please, and do share this to all your colleagues who have not been able to attend this on your college WhatsApp groups, so that they can also come, and more people participating in this discussion can make it more lively for us and for you as well. And I want to thank Dr. Bharat for his time, and I want him to give some final piece of advice to medical students on COVID, because you are the COVID specialist for your city and you are working so hard. So can you guide our students about COVID once more, because a lot of students have asked this question to to me to ask you for this today.
So actually, this is some unforeseen circumstance which happens only once in century. So we are all living in an era, so that is going to gradually change the way of thinking and the way of life. So whatever it is, so this COVID is going to stay with us for a few more days. So make sure you are maintaining personal hygiene. So what I say to all my students is, in this pandemic, the only magic is personal hygiene. So make sure your hands are clean, you're not touching your face and mouth, and make sure you're wearing a good face mask. If possible, you carry a good sanitizer with you, and have that face shield with you. And don't worry, we will all come out of this very, very strong and very, very soon. So I want all my young students, so take care of your health. Make sure you're not missing your meals, you're not missing your snacks. So take good food, build good immunity, stay fit. And this COVID is just a challenge. So we will come out of it as soon as possible. So it was a great opportunity to interact with all of you. So Sumer sir always wants this type of discussion. So already you had some surgery discussion, case discussion. So only if you do it in an integrated manner, it will be integrated better in your brain. So it was a very nice interaction with all of you. So stay safe and make sure our next generation of doctors should learn from you how you dealt with this COVID.
Yes, and I would like to wish you all the best for the upcoming AIMS exam, for people who are giving the exam, and wish you all the best. Stay safe and keep following us on the DAMS Daily channel on YouTube for more such discussions in future as well. We wish you all the best. God bless you. Thank you very much.
Thank you.
Thank you, Dr. Bharat.
Yes, sir. My pleasure.